patients are normal, so
good point. Okay. Is it within the bell curve of that 80% middle, or is it on the edges? So you all think that this is slightly abnormal. All right. So what would be abnormal about it?
It's looping.
It's looping. Okay. But remember, the normal ophthalmic artery goes through the optic foramen with the optic nerve, usually lateral to the nerve, then it goes over the top immediately, and that's what that curve is. That's where it comes over the optic nerve and then goes forward. I'm going to help you out. This is normal. This is a normal artery. Okay, so we've got the first segment, second segment, third segment, and we've got normal branches. What's this branch here? Lacrimal. Good. Where would we expect the choroidal and the central retinal artery to come off? Yeah, somewhere here. Okay, to give this choroidal blush. And then these would be branches to the muscles, to the variable fat, and then of course as we get distally chopped off here, we'll have the supraorbital and supratrochlear arteries. So that's normal. And this is just that same vessel in 3 dimensions. So you can see this is looking from above. Here's the anterior clinoid, this is sphenoid wing, optic canal, there goes the artery, lateral to the optic nerve, crosses over superiorly, and then continues. And there's the lacrimal branch going to the lacrimal gland. What about this one? Has this one got a special feature, or is it normal? Put up your hand if there's something special about this artery.
I think energy is coming from that.
Yeah, exactly. So help everybody. There's the pointer, show where the little meningeal is.
That one's coming.
This one? Ah, I thought you had it. No. So this is actually coming this way, right? This is the temple branch over here. But you spotted the clue. And the clue is really, the middle meningeal is a straight artery. So as soon as you see a straight artery superimposed on top of arteries that have curves in them, think about the middle meningeal. And if you follow it proximally, you can see here, middle meningeal. Look what it does here. This is where the vessel comes around the lesser sphenoid wing, goes through the supraorbital fissure to join up with the ophthalmic artery. Here it is over here. And this pattern, that little bend there, is worth remembering, because that's the pattern that you'll always see with the middle meningeal origin of the ophthalmic artery. What about this one? Obviously you've got severe vasospasm. This is a patient who's had a subarachnoid hemorrhage. But the clue's there. It's what I told you to look for before. The straight vessels, right? So we've got the straight vessel here, middle meningeal. And if we look at the 3-dimensional picture, again, this is looking from above. So here's the anterior clinoid process. This would be the carotid coming through the cavernous sinus. There's the ophthalmic artery, and here's the branch at the level of the lacrimal branch that comes up through the supraorbital fissure. You see the little hook that it has? It comes around the lesser sphenoid wing and takes the normal middle meningeal territory. Same thing, looking through the orbit, and you can see, just to show you the vessel going through the supraorbital fissure. So this is medial, this is lateral, optic foramen, supraorbital fissure, and there's the branch going through the supraorbital fissure. And if we look from exactly the opposite direction, so this is posterior, there's the anterior clinoid process, there's the lesser sphenoid wing, and here through the supraorbital fissure comes the middle meningeal vessel. So this is what Insuk showed you this morning, and the way to remember the vessels that supply the orbit is the different tissues of the orbit. So we've got central nervous system, retina, and that has a supply from the ventral ophthalmic. Why does it come from the anterior cerebral artery? You didn't think about that. Why would the supply to the eye come from the anterior cerebral?
Anticipal artery is the oldest artery.
Well, yes, you're right. So the cranial division of the internal carotid is an old artery that's present right there. But why would the supply to the eye come from there? The answer is that it's the closest artery to the optic vesicle as it's extending out. So it's diametric structure. It's going out there. So that's where the artery comes from. That's why it extends from this cranial division of the internal carotid, because it's the closest region that it can come from. So that's the supply to the central nervous system through the orbital fissure. Then we've got supply to the peripheral nervous system, and of course it's going to follow the peripheral nerves. So we've got the dorsal ophthalmic that's going to be the blood supply to the third, fourth, sixth, and V1 part of the cranial nerves. So we've got supply to the central nervous system, peripheral nervous system, and we need a supply to all the other structures, all the mesodermal structures in the orbit, fat, glands, muscle, and that's going to come from the supraorbital artery, from the hypostachial system. And then, of course, these three separate arteries are going to join together. They're going to be annexed, so that we end up with this disposition where the hypostachial system is left with the middle meningeal artery, the ventral ophthalmic persists because the dorsal ophthalmic is going to regress, and we've got the supply to the whole orbit that's been taken over. And these are the drawings in Pierre's book, where you can see the meningeal origin of the ophthalmic artery. And what's this one called? Meningolateral variant. Right, so where we have the middle meningeal supplying only the lacrimal gland. So let's put that knowledge to use. 60-year-old lady has big meningioma, needs to come out. Useful to embolize this pre-surgery. Where would you expect the supply to come from for this meningioma? So it's going to be middle meningeal, right? That's what we'd expect. Would you inject the internal carotid artery?
Yes, to see the choroid first. I make a diagnostic angiogram.
All right,
Yeah.
good. Here's the angiogram. AP view, late phase. What's going on? Let's start. What's this? That's the easy one. Okay, we'll make it easier. What's this one? Is that what's in the midline? Thank you. It's the anterior cerebral artery. So if this one's the ACA, what's this one? It's the MCA. And of course it's stretched and it's elevated because there's a big tumor underneath it. What's this one? What's this artery? Exactly. So this is the ophthalmic artery, the recurrent meningeal, and the middle meningeal is supplying, of course, the tumor. And if you look on the lateral view, remember the shape I told you to memorize? It's right there. So it's obviously a much bigger artery, but it hooks around out the supraorbital fissure over the sphenoid ring, supplies that whole tumor. So this is all tumor vessels. Safe to embolize, not safe to embolize. Answer answer is it is safe to embolize if you know where you are. So if you know where the vessels come off to the retina, the choroid, then you know it's safe. Because if you get distal to this point, if you get a microcatheter all the way distal and onto the tumor, it's going to be safe to embolize. Just don't reflux to this point. That's the point of knowing all this anatomy. Is if you know where the vessels come off, it's going to make it much safer to do treatments. And this is after embolization. And you can see the whole tumor vessel area is gone, but we've preserved the supply to the eye.
What did you embolize with particles?
Particles. Yeah. And of course, this is what you'd expect if you inject the external carotid artery in this patient, is we would expect not to see a middle meningeal artery. And here we go, here's the lateral view, and you can see there's the superficial temporal artery, no middle meningeal. AP view, same thing.
Would you also you're starting to make the glue to make sure
Sure.
you stay within the tumor and never reflux? Don't use all the disease.
This is a classic picture, right? So you can just tell me what it is. Nothing else looks like this. Come on, radiologists. Come on.
Yellow bars.
Yes, it's an anterior cranial phosphodural fistula. So as soon as you see something right there next to the falls, and it's big and fat, it's not going to be an artery, it must be a vein. And if there's a vein in the anterior cranial fossa, it's going to be an anterior cranial phosphodural fistula. What's the supply to that area of dura? Ethmoidals. So yes, the ethmoidals will give meningeal supply to that area. It will give the false line area and the cribriform area supply. So we're going to have ethmoidal supply, which comes from the ophthalmic. What else? They usually get contribution from other vessels as well, little meningeal, even facial through the nasal area. So you can have lots of supply to this area, okay? But we've got ophthalmic supply. So let's look at the angiogram. I'm just putting up one picture. And again, here we've got ophthalmic artery, ethmoidal, coming up to the cribriform area. Tell me when we get to the fistula. So we got ophthalmic artery. All right, good. So that's our target, right? If we're going to treat this. Is it safe to embolize through this vessel? I gave you the answer. Yes. As long as you know where you are. Because the supply, you do not want to embolize anywhere close to this point. So you've got to get your microcatheter all the way right up close to the fistula. And that's what we've done, right? Microcatheter. It's done a couple of loops in here, really close to the fistula. If you had to inject this, what embolic agent would you use? Okay, 1x EVOH. What's the problem with that? Reflux, right? You've got to create a plug and we might get close to right there, which would be dangerous. We don't have that much room to play with. You could use a balloon, you could use a pressure cooker technique and trap it. But I chose to use glue. There we go. You can see glue building up at the, there we go, on the vein. And then before we reflux too much, we stop. The nice thing about glue is it's very thrombogenic, right? So I don't have to get it casting the whole thing. It's going to occlude nicely. And then afterwards, we've preserved the ophthalmic artery in the patient's vision.
You use magic for this magic? Magic?
Yes.
What concentration of glue did you use?
The concentration that's needed.
For your rule to penetrate, right? You don't want it to glue proximally as the media supplies us. So I think liquid glue as close to the tissue as possible without reflux.
Yeah. So Timo's going to speak about this, and that's why I'm not going to go into too much detail. But there's lots of variables for injecting fluid. The rate of flow, the size of the catheter, the patient's blood pressure. And those are all things that determine the concentration of fluid that you're going to use.
I think one important feature of this type of fistula, when you think about using onyx with onyx, unless you are using a center-mini balloon, you will have reflux. And the problem is the harpoon shape that you are in. When you are having the reflux, and the reflux is, even if it's in a close or in a safe segment, i.e. just above the harpoon, above where the central retinal artery comes off, you have glued or onyxed your catheter in a non-straight segment. Okay? If you are onyxing, or if you have onyx around your catheter in a straight segment, you can always pull it out within like 20 minutes. But if it's in a bent segment, then you will force the catheter to straighten the vessel. And when it straightens the vessel, we had one case that I was an expert reviewer who was blind after the embolization, and it was not because the patient had reflux, it was because the central retinal artery was torn off. Okay, so I would strongly recommend you, if you treat there, either go transvenous, and this was not possible in this case here, or go as distal as possible and use glue, because then you will not have this problem that you have with onyx in non-straight segments. So be very careful with onyx if you're like in the bent vessel, because you will straighten it and this will tear off potential perforators down.
Surgery.
And surgery is also very good option.
Good option. So a little bit adding the technique, because as Timo say that we plus a little bit more diluted when we go that point, because you don't want any millimeter of reflux. Okay, and even that withdrawing the catheter must be soft and whatever. So as Timo said that, in this very small artery, it's already you have some glue at the tip, which is probably need to be very cautious.
Good points. So 2 quick cases. You're familiar with this drawing that Insuk showed you this morning. I'm going to use it to work out what's going on here. So we've got right subclavian, left subclavian, right carotid, left carotid. That's not the normal order. What is this? It's not the common one. The common one is what? The most common variation of the arch. The aberrant left subclavian. That's not this.
It's a right arch.
Yes. Did you see the catheter?
Yes.
Yeah. Okay. So can you see the catheter comes? It's a pigtail catheter. It's coming up this way and turning there. So it's a right arch. How do we get that? Can we draw it off this? So the first thing is we have to get rid of the left. So what happens is if the fourth aortic arch on the left doesn't develop, we're going to get persistence of the arch on the right. And then if we follow the route of the catheter out, we would have left subclavian, left subclavian, right subclavian, right internal carotid, right common, then left common carotid. Does that make sense? If this doesn't develop, this is going to persist. And then the only place this vessel you can see is going to be larger. Let's just go back to that. because that's the persistence of the dorsal aorta. Good. What about this one? We've got something here. Then a common origin, it looks like, for all the vessels. So, subclavian, common carotid, left common carotid. What's going on? Persistence of both? No, it's not that. So it's not persistence of both fourth aortic arches. What have I told you? It's exactly the same as the other one. Is that it's not a right aortic arch, but it's an axis of the fourth aortic arch on the left. So it's a tight coarctation or complete closure of the vessel here. This is a bypass graft that's been done when this person was a child to allow them to live. And then, of course, this is just the origin of the vessels. So it would be this. Left-sided fourth aortic arch is absent, bypass graft over here, and then the trunk is giving rise to subclavian common carotid. There we go. So this is absent, blocked off there. Subclavian common carotid. Good. All right. Who's next?